continue to grab their food and make themselves comfortable. I'm Terry Batliner. I'm the Associate Director for the Center for Native Oral Health Research, which is in the Colorado School of Public Health, directed by Dr. Albino. Hi. So I'm very happy to have our speaker today. He's become a friend of mine, and I think a guy who's a real leader in healthcare in the United States. Dr. Al Yee is a physician. He's an internist who went to Tufts. He also has an MPH from Columbia. He's currently the Senior Project Director and Health Advisor for the Education Development Center in Newton, Mass. And prior to his work in Newton, he was a project director at the Kellogg Foundation in Michigan. So take it away, Al. Thank you.
Thank you, Terry. Thank you very much, Terry, and good afternoon, everybody. I have two apologies to start off with. First apology that I have is that I hurt my knee a few weeks ago, and sometimes it's better when I walk around a little bit. Sometimes it's better when I sit down. Sometimes it's better when I stand still. I can't predict. So I'm going to be moving around a little bit, and hopefully that's not too distracting to anybody. So that's my first apology. The second apology, two people came up to me today, just now. Actually, one asked me politely, because I just met that person, if I brought the ring from Massachusetts. The other one, Terry, accused me of bringing a ring from Massachusetts. So that's my second apology. If I did or I did not, I apologize in advance. So again, thank you for this opportunity to be here this afternoon to speak with you, and really to have the opportunity to speak about a specific project that I've been actually privileged to be a part of over the last few years, and a project that I've really developed some passion for, just being involved in it, again, over the last few years. So Terry, when he asked me to come here to speak, really asked me to speak about philanthropy and how philanthropy can influence health policy. That was the topic, right, Terry? I just want to make sure I got it right at this late hour. But he asked me to actually speak specifically about a particular project, the Dental Therapist Project, which the Kellogg Foundation has been involved in for the last several years, and really to use that as a case example of how a particular foundation is trying to influence policy on the ground, again, through this particular project. I'll be spending most of my time talking about the Dental Therapist Project. And before I actually jump into it, I just want to clarify my role with the project and my role with the foundation. As Terry said, I'm presently at an organization called EDC, and in that role, I actually have some consulting time for the Kellogg Foundation, and that's how I remained involved with the Dental Therapist Project. Prior to being at EDC, I was at the Kellogg Foundation, as Terry said, as a program director or program officer. And while I was there, I had the privilege and the honor, and I guess the blame from some people, to get the foundation involved in the dental therapy agenda about 6 years ago now. So it's been a little while. And so I guess of all the people now involved with the Dental Therapy Project at the foundation, I probably have the longest continuous involvement with the project. So what you're going to hear from me today is not only some description about the project and the role of philanthropy, but also some historical perspective as well, and I hope that would be interesting for you. What I'd like to do as we get started is for the presentation, the formal presentation, I'm really going to talk a little bit about oral health access issues first, because I really want to provide some background information and some context for some of you that might not be as familiar with oral health access problems, so you can understand why the Kellogg Foundation got involved in this work and why it continues to stay involved in this work. And then I'll give a description of what and who dental therapists are, because I know some of you are familiar with them and some of you probably are not. And then I'll talk about, again, the historical perspective, how we got involved in this work through the Kellogg Foundation, and then how the Dental Therapist Project has evolved since then, including some recent developments. And then I'll end the formal part of the presentation to mention how the foundation has used certain philanthropic strategies to really advance the work. Again, how philanthropy can influence health policy. And then hopefully we'll have some time at the end for some questions and conversation. First, let me actually say a few words about the Kellogg Foundation. The foundation is a large, actually international foundation, although most of its funding is domestic, and as Terry said, it's based in Michigan. It's been around for over 80 years now, and I do want to mention that it's different and separate from the Kellogg Company, which I'm sure all of you are familiar with as well. But it's a totally separate entity. It's a different legal structure, different governance structure, and a totally different mission as well. So they operate independently of one another, the foundation and the Kellogg Company. In terms of its mission, and I'm sure all of you know that philanthropy foundations, by and large, many of them, the purpose for their existence is really to identify and address unmet social needs. And the social need for any one foundation can differ from one foundation to another. And for the Kellogg Foundation, its particular mission is to improve the lives of children and to promote optimal growth and well-being, and with a special focus on vulnerable children and children from underserved families and children. So that's really the mission of the foundation. And the programming priority areas that you see listed up there really are in the areas of promoting racial equity and doing some programming areas in education and learning, food, health, and well-being, economic security, and then promoting civic and community engagement as well. Probably most germane to this particular conversation we're having here today, the foundation really has a long-term commitment to improving the health and well-being of underserved populations for decades all over the country, including oral health. And when I was at the foundation, we did a sort of a cursory review of investments in oral health through the foundation in their health portfolio, and learned that they actually invested over $50 million in oral health programming over the years. And the dental therapy project, therefore, is really just a continuation of this long-term commitment that the foundation has to oral health and overall health. And fortunately, the dental therapy project is really well aligned with the present-day priorities for the foundation. As I said at the beginning, I really want to spend a few moments to talk about access issues in oral health. And what I'm really going to do is I'm going to actually plagiarize and talk about some of the findings and quotes that came out of the IOM report, the recent IOM report on access to oral health care. And for your information, the title, I don't know if you can see it clearly, of the report that came out earlier this year is Improving Access to Oral Health Care for Vulnerable and Underserved Populations. And again, I'll be talking mostly on the next few slides about what came out of the report. But first, I just want to mention, for those of you that may not know, the Surgeon General report that came out about 10 years ago, in the year 2000, really was a landmark report that really put oral health, I think, on the map nationally and in a really high-profile nature. And it was essentially a call to action to address oral health needs in this country. And 11 years later, we have the IOM report, which essentially says, since that report, a lot of work has been done, but it's not enough, and a lot more work needs to be done. And that's sort of the summary of what they said. Getting into a little bit more detail, these are just a couple of data points that they use in the report just to highlight some of the access issues in this country. In any given year, more than 50% of people actually do not see a dentist, and about over 30 million people that are unserved actually live in what's called dental health professional shortage areas, where there are simply not enough dentists in those geographic areas. And for those of us and others that have been working in the dental access world, I think it's general acknowledgement, and though this is not mentioned in the IOM report, about 25 to 30% of the general population really does not have good access to dental care in this country. And so what are the consequences of poor access? The consequences of poor access are clearly poor oral health, but what's not clear to a lot of people that haven't gotten into this work, that it also has implications on overall health as well. So what you see here are some comments from the Institute of Medicine report, where in addition to pain and suffering, poor oral health is associated with malnutrition, childhood speech problems, and serious and sometimes fatal infections. And unfortunately, we hear too many of those stories these days. And it's also associated with certain systemic medical issues such as diabetes, heart disease, and also premature births. And we also know, again, through the report, that dental disease can be transmitted from mom to child and can perpetuate the cycle of dental disease in future generations. It turns out that not everybody is equally at risk for poor access and poor oral health. Unfortunately, there are certain populations that are more at risk than others, and the IOM report sort of listed those subpopulation groups that they felt are more at risk. And I'll just quickly read them for you, and you can see it as well. The racial and ethnic minority populations, including immigrants and non-English speakers, children, especially those who are very young, pregnant women, people with special needs, older adults, individuals living in rural and urban underserved areas, uninsured and publicly insured individuals, homeless individuals, and populations of lower socioeconomic status. So those are the sort of the high-risk population groups that the IOM report identified as having the risk of low access to care and low oral health status. So those of us that have worked in the health access arena for a number of years now realize that trying to address access issue is a real complex problem, and you really need multiple solutions to try to address these problems. And the IOM report appropriately came up with a number of recommendations to address these access problems. But what I did was I pulled out, in the next slide, really just a few of the recommendations that are most pertinent for our conversation today, which has to do with workforce recommendations to address the access problems in oral health. So these are just a few of the references that were in the Institute of Medicine report that talked about workforce, and I'll just read them quickly. They described a vision of improved access that relies on a diverse and expanded array of providers that are competent, compensated, and authorized to provide evidence-based care. One of the conclusions states that improving access to oral health care will necessarily require multiple solutions, which I mentioned, that use an array of providers in a variety of settings. And the last one here, there was a specific recommendation for HRSA, or Health Resource Services Administration, which is a federal agency, to promote innovations in oral health care delivery, such as new workforce models. And that's a perfect segue for me to finally get into the topic that I'm here to talk about, which is dental therapists. Again, this is all background information. Dental therapists actually is one of those new workforce models that are being proposed for the dental profession. So with that, what are dental therapists, and who are dental therapists that we're talking about? They're essentially dental providers. And what I found speaking to people about this, that the easiest way to understand who dental therapists are, just think about nurse practitioners and physician's assistants on the medical side of things. It's not exactly the same, but conceptually it's similar. People have also used terms such as mid-level providers or alternative dental providers, and those are more generic terms for dental therapists, and dental therapists is a more specific model of mid-level providers, and that's the one we're going to be talking about for the rest of our time together here. So dental therapists, again, are dental providers. They deliver prevention services and routine care under the general supervision of dentists. So the key points here are that they're part of the dental team, and that they're supervised by dentists who lead the team, and they do not practice independently. Those are the key points I wanted to highlight there. They do, within their scope of practice, they perform limited restorative procedures, which include some drilling, some fillings, and some simple extractions. And for those of you that might ask, how do dental therapists differ from hygienists? That's one of the core differences, that hygienists basically do not do the restorative procedures that the dental therapists do. So I just want to say that to differentiate the two professions. Another very key thing I wanted to say is that dental therapists actually, although some of you are hearing this new, actually been in existence for almost a century now. They started in New Zealand 90 plus years ago, and they were, I think, called dental nurses back then, but over time, their titles have evolved to dental therapists. And they're now established in over 50 other countries. They're established in Canada, in Great Britain, in Australia, Netherlands, and many other countries. And the first dental therapist to practice in this country actually practiced in Alaska in 2005. You're going to hear a lot more about that program in a second. And then this year, dental therapists started practicing in Minnesota as well. So you can see some of the evolution internationally to domestically. Just a few additional points that I wanted to bring up about the model. Dental therapists actually improve oral health by both increasing access to care and also prevention. You're going to hear me talk primarily about access today, but I don't want to sweep under the rug, the fact that they actually do a lot of prevention work and a lot of health promotion work as well. They do individual prevention work when they're patients in their dental chair. They also do community promotion outreach programs as well. So I just want to mention that, even though we probably won't touch upon that through the rest of the talk. There's a strong evidence base that has demonstrated that dental therapists provide good quality care. And I'll be getting back to that in a few minutes. The program that we're most familiar with, the program in Alaska, there's a strong emphasis in not only saying that the dental therapists provide good quality care, but ensuring that they continue to provide good quality care through the training programs, through the supervisory models, and through any processes that they put in place to support the dental therapists working as part of the dentist-led team. So there's always a strong emphasis on providing good quality care. And also the program that, again, you'll be hearing a little bit more about in Alaska really began, so it's really the first program of its kind in this country. It really started off as a local community solution to address a local problem, which was, if you recall early on, in terms of the Kellogg Foundation priorities about civic and community engagement, that really resonated very well with the community, with the Kellogg Foundation in terms of its interest in this particular model. And because it really was a local community solution, cultural competency was actually embedded in the model. And because of that, they were able to take care of a lot of the local cultural issues that the providers were facing with the residents. And also because of that, this really allows the model to really have a strong focus on health equity and addressing health disparities as well. And another key attribute I put here, innovative in quotes. Now, obviously, it's innovative in this country, but as I said earlier, it's really been established in 50 other countries for a number of decades now. And the last thing I want to say is that we don't believe that dental therapist is the be-all and end-all, because you're going to hear me advocate about it, as I talk more about it. I get more excited as I talk about it. But be that as it may, we don't think it's the be-all and end-all. It's not a magic bullet. And as I said earlier, to try to improve access to care for underserved populations, it's complex. You need multiple solutions. We think it needs to be on the menu. It needs to be considered as one of the options. So, back to philanthropy. How did the foundation get involved with dental therapy? We were actually, frankly, the simplest answer, we were invited in. That's how we got involved. We received a proposal about a training program, and I was actually minding my own business, sitting at the Kellogg Foundation, not knowing what I was going to get into, and this proposal came across my radar screen. But just stepping back a little bit, Alaska Native tribes about a decade ago, realized that the residents in Alaska in the villages really had poor oral health status, and this was based on health indicators that they were aware of and everybody was aware of, that Alaska Natives have oral health status about 2 to 3 times worse than the general population, and they knew that. They also realized that because of the geographic nature of the villages being isolated from one another, because of the highly rural nature of Alaska, they had tremendous difficulty recruiting and retaining dental providers. And so their system, if you want to call it a system, their system of dental care was actually flying in dentists once a year, once every other year for a week or 2 weeks to provide dental care for residents in those isolated villages. And in between, there was like no dental care whatsoever. And only if someone had an emergency would they be flown off to one of the hub cities, which could be very expensive. So that was what they were working with, bad oral health status and really poor access to care. So they basically scratched their head and looked at other opportunities, and they discovered the dental therapist model, and they discovered it at its source in New Zealand. Even though it started almost a century ago, they actually spoke to people in New Zealand and learned about the program in detail and started to send students to New Zealand to be trained and then to come back to work in their villages. So that's really, again, the local solution that they created for themselves. And then back to what I said earlier, so that's when they invited us in together with some other foundations. They sent us a proposal and said, hey, we really don't want to send our kids all the way over to New Zealand. We can set up a training program here closer to home on American soil. We would love to do that. Would you be interested in partnering with us? And on the surface, that made a lot of sense, and that obviously intrigued us for all kinds of reasons. But I'll be the first to admit, seeing I did the initial review and had to sort of sell this, and I was really skeptical from the beginning about the proposal. And the reason I was skeptical is because I learned that dental therapists basically had 2 years of training after secondary school in order to do the work that they do. So they essentially have an associate's level degree. And when I learned that they were doing some drilling and filling and extraction, I got really, really nervous. And I said, what's this all about? Because I haven't been trained in the healthcare system here. My dentist colleagues, have 4 years of training after bachelor's degree in order to do a lot of the same work. So at first, it just didn't resonate and didn't make any sense to me. But at the same time, we were obliged and we wanted to do some research and do some due diligence process to better understand this phenomenon, actually. And what we learned, number one, as I said earlier, this is not an experimental model. It actually existed about a century ago. And wow, it's an established model in 50 other countries. What are we missing here? Something is going on with that we couldn't, we didn't understand at the beginning. And then we got our hands on some studies that were done that actually looked at the quality of care provided by dental therapists. And what we learned in these studies, they showed that at least for the restorative procedures, which is what they looked at, that dental therapists provided good quality care, as good as that provided by dentists for the same procedures. And that sort of floored us. And the epiphany we had, well, I'll speak for myself, the epiphany I had for me to understand this was that dental therapists basically don't do everything that dentists do. They do a limited scope of practice. But what they do, they're trained to do, and they do it over and over and over and over again. So they become quite technically proficient in what they do. So then all of a sudden everything came together and made a lot of sense to us why this model worked in other countries and why we should consider it in Alaska. So with all that as background, that's how we eventually got into the dental therapy world, invited in and having to do this research. So the foundation, together with other funders, local funders in Alaska, funded a training program, the first of its kind, again, on American soil, and it was a partnership between the Alaska Native Tribal Health Consortium and the University of Washington. They developed this training program, which is based in Alaska, and it's still basically, it's ongoing, and the Kellogg Foundation continues to fund it. And I put here some of the rationale I was thinking that we went through, and I guess this was the rationale I had to use to convince the foundation to jump into this. But basically, what we said was that there's severe ongoing unmet oral health needs in the Alaska Native villages. They tried everything they could think of, it just wasn't working. What they were considering was not experimental, it was an established model elsewhere. And again, most critical were the studies that I just mentioned to show that dental therapists provided good quality care, because otherwise we would not have gotten involved in this. And I guess the other piece that I want to mention that I forgot to mention earlier is that at that time we were asking people if they knew of any studies that showed the contrary. Were there any studies anywhere that showed that dental therapists do not provide good quality care? And we couldn't find any studies then, and we still haven't heard of any studies since. So the Kellogg Foundation is still involved in supporting the program. By the time the funding ends, it will more than triple the number of dental therapists practicing in Alaska on the base of the dental therapists that returned from New Zealand. And since then, the foundation is very much committed to advancing the dental therapy work. After it started funding this is the historical piece. After it funded the training program, I retrospectively now call the next few years sort of a learning and sharing information phase. And we went through a phase where we really wanted to learn more about dental therapy and wanted to share the information broadly to people who were interested in learning about dental therapy and also access issues in this country. And we learned primarily from our experience with the Alaska Dental Therapy Program and some international experience, but we were also in a position to also fund and support original studies and original work as well. And I just want to mention a few of them to you right now. We funded a report by Dr. Bert Endelstein from Columbia University and the Children's Dental Health Project. And basically, he looked at training programs across the world in terms of dental therapy. And what he learned, and which we found validating for us, because we couldn't do the extensive research he did, but he basically validated the standard of training for dental therapists was 2 years after secondary school, which was, he found other things too, but that was the key finding out of his report. We also funded an evaluation of the Alaska Dental Therapy Program as well. It wasn't the evaluation of the training program, which we just funded. We actually evaluated the practice program in the field of the dental therapists that trained in New Zealand and came back to practice in Alaska in the villages. So that was the evaluation, really evaluating what their practice in the field and seeing patients. And what the RTI evaluators found was that dental therapists deliver safe, competent, and appropriate care. And they were very careful of choosing these words, let me tell you. But safe, competent, and appropriate care within the scope of practice, which reaffirmed all the prior studies that I had mentioned to you, which again was a sigh of relief for all of us when they had that finding. They also learned that the patients were highly satisfied with the care that was provided by dental therapists, which is, really one aspect of quality of care when you talk about it. And the community residents were very pleased with the ease of access now that they had dental therapists, again, working with dentists in their villages. And just as an aside, I put here just to remind me, I had a conversation with Mary Willard, who runs the program in Alaska. She's telling me now that dental therapists out in the field now are serving up to about 35,000 Alaska Native members who previously had the sporadic access to care that I talked about. Now they have regular access to care in their villages. And another report that we supported was through the American Association of Public Health Dentistry. And this organization pulled together a panel of expert dentist academicians, to look at a training program and what it might look like in this country. And they came up with some recommendations, and it was published in a special issue of the Journal of Public Health Dentistry just earlier this year. And what they came up with was certain competencies and a curriculum for a 2-year training program for dental therapists. And they also advocated for advanced standing for dental hygienists, giving credit for their prior training and experience, so they could have just one more year training to become dental therapists. So that was really the outcome of their recommendations. Interestingly enough, we found out during this learning and sharing phase that a few years after we started funding the training program, that others were actually getting into this topic area, which we thought was wonderful. It was fantastic. And others were actually coming up with reports as well. And we were learning from these reports, but we were also helping to share these reports with others, again, that were interested in learning more about dental therapists. And the Pew Charitable Trust did a report on the financial modeling for dental therapists in clinical practices, and that was a very helpful report. The United States Government Accountability Office, the GAO, also did a child's oral health report, and in the report there was a section on mid-level providers and dental therapists as well. The Robert Wood Johnson Foundation has an annual anthology report. They have stories in the report about certain of their grant-making experiences, and one of the stories had to do with the dental health aid program in the Alaska Native villages. And for your information, the dental health aid program is a big program, and dental therapists is part of it. So they did a whole story about how everything led up to eventually the culmination of the dental therapist program. And then the California Dental Association, in their journal, had a couple of historical and informational articles on dental therapists that they made available for their members as well. Actually, in addition to learning about dental therapy, the foundation also wanted to learn more and better understand some of the oral health issues facing Americans in this country beyond Alaska. And we basically came up, in a much less rigorous, probably much less scientific way than the IOM report. We landed pretty much in the same place as the IOM report. As I mentioned earlier, based on what we learned, 30% of people in this country really do not have good access to dental care. And the situation is worse with racial minority populations and other subpopulations like those that were mentioned in the IOM report. In the workforce projections, these are the information we were getting from ADIA and from other sources that the demand will outstrip the number of dentists in the future in terms of graduating from schools, and when you match that up to retiring dentists as well. So that was a significant concern out there. And there's a maldistribution of dentists as well, dental providers with not enough dentists practicing in low-income and geographically isolated communities. And also because of low Medicaid reimbursement, it's difficult for many dentists to take on Medicaid, and it's challenging. And so, and we recognize that. That being said, the bottom line is a lot of Medicaid beneficiaries just don't have good access to dental care. And so the conclusion we had, which is, again, strikingly similar to what the IOM report said, was that efforts to date have not been sufficient in many rural, inner city, and minority communities in terms of trying to improve access to care, and that one should consider something new. And our newness, you know what that is. And again, as I said, when we talk about the publications, we were also learning during this phase that other folks were not just getting into the dental therapy agenda by doing publication. They were actually doing some real underground work as well relative to dental therapy. And just a few examples here. And this was a real breakthrough, actually. In 2008, the Minnesota Safety Net Coalition that really was involved with trying to improve access to care for the underserved populations were looking at oral health, and they discovered the dental therapy model in Alaska. And so they eventually proposed legislation that was passed in 2009 to train dental therapists and allow them to practice in the state of Minnesota. And the first graduates just graduated this year and started to practice in Minnesota this year. So that just happened. The Pew Charitable Trust is another foundation, and a couple of years ago they launched an oral health, a children's oral health campaign, and they had several strategies, strategic arms in their initiative. And one of them, though, is to improve access to care through new workforce models, including mid-level providers and dental therapists. So they were also on board with this agenda. And even a few state dental associations were looking at dental therapists as a potential opportunity to address access issues in their states. So when we reflected upon this maybe about 2 years ago, we realized that the environment was clearly changing from when we first got, when I say we, when I was with the foundation, when we first got involved in this topic, that clearly the Alaska Dental Therapist Program was getting more established, more and more information was getting out there, people were learning more about dental therapy, and the great thing was there was growing interest and people were jumping on board, getting involved with the dental therapist agenda. So with all that is the environment around us at that time, about 2 years ago, we started planning for our next phase of work, and we launched that last year, and it really was based on the evidence that I've shared with you about the good quality care and the better access, and the belief that dental therapists at least have the potential to help address access problems in communities where there are no dentists or just not enough dentists. And so what we did last year in 2010, we collaborated with coalitions in 5 separate states to really raise the awareness and provide education about the potential for dental therapists to improve access to care. And those are the states that you see listed there: Kansas, Ohio, New Mexico, Vermont, and Washington. And at a very high level, this sort of describes the work that's happening actually still happening in the States. So we started last year, it's happening now in the States. So the way that this has been working is that the Kellogg Foundation provided grants to a lead organization in the state. They would then build a broad-based coalition, basically to try to advance this particular effort, to look at access to care and the potential for dental therapists. And they would communicate broadly, provide a lot of education for stakeholders throughout the state about the issues and the opportunities. And then similar to Minnesota, the goal is for them to eventually come up with legislation recommendations that would allow dental therapists to practice in those states. I want to emphasize here, though, that for that piece of work, the legislative and lobbying work, the coalitions are actually getting funding from other sources besides the Kellogg Foundation, because other funders can actually fund the lobbying piece. And so they've had to, and we've helped to also bridge some relationships with other foundation partners. So to date, 4 of the 5 states actually have proposed legislation that's under consideration in the states, and the 5th will be submitting a proposal for legislation in the next session. And I also want to mention that in several of our states, American Indian tribes are actually part of the coalition as well. What's really been a really pleasant surprise in the last year and a half is that, again, when we first started this, we were a little myopic. We were just thinking about the Kellogg work, but then slowly but surely, we started to hear about other folks getting involved, as I mentioned, with some of the examples. But really, I think in the last year and a half or so, we've really seen a lot more energy out there, a lot more conversation out there about dental therapy. And so it's not just in those 5 states that we're working in and partnering with. There were other states very much involved as well. And I mentioned earlier the Pew Charitable Trust and their Children's Oral Health Campaign, and one of the strategic arms is looking at mid-level providers and dental therapists. They're working in 3 other states, and you see them listed there: California, Maine, and New Hampshire. And I guess the most pleasant surprise really is that a handful of other states on their own, meaning energy organically is bubbling up from within without any influence that I can think of from Kellogg or Pew Charitable Trust folks at the national level, where there's interest to look at dental therapy to address their local access issues. And in these other states where there's significant conversations or activities, they're having things like activities such as conferences and educational opportunities to raise the awareness of dental therapy, also to do research to see what the access needs are in more detail in the states, and again, and the potential role for dental therapists. Some are, in fact, considering also moving forward with changing state practice acts to allow dental therapists to practice, and a few are actually considering how to do pilot dental therapy programs as well. And as you can see graphically, in terms of the interest and the conversation and activities going on dental therapy, in 2005, there was Alaska alone. In 2009, Minnesota came on board, as I mentioned. And I had this updated the other day, this graph. And to my knowledge right now, there's about 17 states right now that have either significant conversations or activities going on to try to promote dental therapy as an option to improve access to care for underserved populations. And this is not just actually happening at the state level. That's where most of the activities are, but it's also happening at the federal level as well. And it actually was happening at the federal level pretty early on when the Alaska program got off the ground in the early 2000s. The Indian Health Service from the federal government was supportive of this. In fact, they had to be before the Alaska program could go forward. So there was federal support even at that point. There was a recent GAO report that I mentioned that had a section on mid-level providers and dental therapists. But I think the most important one is what came through the health reform or the Accountable Care Act, where there was actually legislation in place that actually allows for demonstration pilots to happen for what they call alternative dental providers. I mentioned that earlier as a generic term, and that can include but not limited to just dental therapists. So clearly, from my perspective, the momentum has been building and it continues to build for dental therapy in this country. And quick summary form, this is, I think, how it evolved. It started off as a local solution from the Alaska tribes in the state of Alaska, and then they invited some foundations in to help them start a training program. And then the foundations and other partners, not-for-profits, really started to share the knowledge and information that they were gathering from their experiences and from whatever studies that they were able to get their hands on, and made it much more widespread and known to others. And then people and organizations on their own really took up this agenda. And I think that's how it's been evolving from villages to states to other states and federal as well. So that's really the story of dental therapy. And I just wanted to then shift over now to talk a little bit about the philanthropic part of it, because again, we were talking, the purpose of this conversation is really to say, how does philanthropy influence health policy? And I wanted to give that case study so that you'll know a little bit of what I'm referring to when I talk about some of these strategies. So there are a number of philanthropics. I know there's some funders in the room. They're going to say, you missed out on something, or this is inaccurate, but bear with me. I'll do my best here. And feel free to chime in if I do indeed miss something. But there are a number of strategies that the foundation employed to try to advance the work. And again, I'm going to use some of the activities through the Dental Therapist Project, which you're now very familiar with, to illustrate some of the work. But the first thing I want to mention is that any large project, or maybe even a small project, but any project initiative that tries to address the social need needs to go through a pretty rigorous review and approval process in the foundation before you would even get supported. And so you have to find out whether or not this is aligned with the foundation's mission, whether it's aligned with the strategic priorities, and frankly, it needs to compete against a bunch of other really good ideas, projects, and initiatives for relatively scarce dollars. So the Dental Therapist Project went through this exact process at the Kellogg Foundation. It took months to sort of go through that process, and eventually it did get approved, and then we were able to actually employ some of the strategies that I'm going to mention. So one of the major strategies, which I'm sure is most commonly known out in the field, is that foundations give out money. So, and give out grants and gives out contracts. And there are different kinds of grants and different kinds of contracts they can give out. And in fact, the Dental Therapist Project clearly took advantage of this. And there were a number of different grants and contracts that were made to advance different bodies of work related to the Dental Therapist Project. So just a few examples here. We gave us some planning grants, and probably the best example, and that's obvious, self-explanatory what those grants are for. We give a planning grant to an organization that really did a lot of good research for the foundation about the different states, and really sort of, where are the opportunities in the states that one might want to partner with if you want to go into the next phase of work. This was a couple of years ago. And that was very helpful in terms of guiding the foundation to know which states with whom they wanted to have conversations and then eventually partner with those states. So that planning grant was extraordinarily helpful, and that organization has stayed on and has actually taken the lead in coordinating the state strategy and actually providing training and technical assistance to the state coalitions as well. There are pilot demonstration grants, and although we didn't do this proactively as a pilot demonstration model, where you sometimes give demonstrations to a lot of different sites and then study them, in retrospect, I would argue that the training program that we supported initially really was, in fact, a pilot demonstration program. It was the first of its kind in this country. It was a pilot in the system. Not everybody knew where everything was going to fall. And it was a real learning opportunity for the people involved with that program to identify what the challenges were, what the barriers were, and how they were going to address all of them. And to their credit, I can tell you that the programming partners in Alaska, they were great. They were very, just to let you know, a lot of folks, grantees, like to hide, warts from the funders. They were the opposite. They worked with us as true partners and really said, we're having problems with this, we're having problems with that, what do you think? And we're really just part of a team trying to solve the problems. And they were great in doing that. And they're even continuing to sort of share the lessons learned from the training program to this day to anybody that wants to learn about what happened and what is happening with their training program. So I would categorize that as a pilot demonstration grant. There were some capacity building grants as well. And the way I view this is these are grants to organizations basically to build up the infrastructure, to build up the capabilities to take on a certain body of work. And I would argue that the grants that we've made to our coalition partners in the states really fit into this particular bucket of grants. They're capacity building grants to help the coalitions do their work better. So the coalitions had to build the coalitions, to strengthen the coalitions. So actually many of them were not in the oral health field. They were children's advocacy group, health advocacy groups, rural advocacy groups, and they all came together, and they really need to learn about oral health and dental therapy. So we provided the funding and some training and technical assistance to get them up to speed, working with each other, understanding the topic area, giving them the skill set to strengthen the ability to communicate what they were learning, to develop strategic plans, and also to advocate on behalf of the model. The other types of grants and contracts that were made, I mentioned earlier in terms of original reports and studies, and so I won't go over them now, but a number of studies were funded through this particular project. Excuse me. So beyond money, beyond the funding of grants and contracts, communications was an integral part and is an integral part of this project. really have to, if you're talking about influencing policy and health policy in this particular domain, you really need to provide information to stakeholders and the policymakers so they have all the right information they need in order to make whatever decisions they're going to make. So communications is an integral part of this particular project. And in addition to the publications I mentioned earlier, we actually partnered with some communications expert firms, and they helped us develop some educational materials, helped us develop some informational messages, and then we worked together with them and others to deliver and disseminate this information as broadly as we can through various media channels, print media, web-based media, presentations at conferences, at meetings, and even testifying at hearings. And the dental therapist program really looks at the communications work, again, as critical to all the strategies that we're using to try to advance this particular agenda. As I said, policymakers need to get the information in order, as we like to consider, to make the right decision. Convenings also turning out to be a very valuable philanthropic strategy that we've been employing to help advance the work, whether we're talking about convening a small group of people with a specific aspect related to the big project, or really just having convening, sharing information about the big project with all of you and others, has been very helpful. Just having a dialogue and being able to share information and networking opportunities really has helped to move the momentum forward. And we've learned that individuals or groups actually do take action after some of these convenings. And the other valuable thing is, by having these various convenings, we've found that we've been able to enlarge the tent, invite more people in, and get more and more people involved with the work. You can really help to advance the goal of what we're trying to achieve here. We also found ourselves playing a role as connectors, and hooking up people with the right resources and the right knowledge. And this is probably best exemplified by those handful of states that I talked about that on their own, activities bubbling up within those states. Most of them, in one form or another, we've had conversations with, and they would ask us, well, what did you learn from your experience? Can you show us, demonstrate what, what lessons learned there are, what problems, how did you address them, et cetera, et cetera. And we would do our very best to sort of share that information, but there clearly were questions we just couldn't answer. But fortunately, we were in a position in many of those situations to broker certain types of communications or relationships. So, we were hooked them up with researchers. Many people actually asked very detailed questions about the Alaska Dental Therapist Program, and we just didn't know that level of detail. So we hooked them up to Mary Willett or Ron Nagel up in Alaska, and they basically provided the information. We not infrequently recommend speakers for local meetings and local conferences, again, to be able to provide them the information they need, and also we also just hook them up together. The states can talk to each other and learn from each other as well. So there was a very valuable role, I think, that the foundation played as a connector, even if it wasn't directly involved in funding certain work. And then clearly promoting collaboration and partnerships. I think foundations are in a great position to always do that. And not just with money. If you give money, you can have shotgun marriages, but they don't always work. So I think it's always in a good position, nonetheless, to promote collaboration and partnerships if you can do it well. And again, there's a lot of opportunities through this connector role, through the convenings, through the state coalitions. We're promoting collaboration. But the one that I really wanted to emphasize here in terms of our work was we had the opportunity and really made it a priority to try to reach out to and partner with other foundations that have demonstrated an interest in learning about dental therapy. We just felt that was an important piece, at a minimum, to share information. But they're also looking for opportunities to coordinate work and where it makes sense to even jointly fund activities together. And then the last slide I have around philanthropic strategies have to do with lobbying. And the first thing I need to say here is that private foundations like the Kellogg Foundation, does not do lobbying and does not support lobbying. And that's why I made a point of saying earlier that the state coalitions that we're working with, when they do the lobbying work and the legislative work, they actually have to get funding from other sources, and they do. But other foundations can lobby, and they do so because they're under a different legal structure, and I'm actually not an expert in that area. There may be some other experts in the room that may know. I'm looking at someone right now, but I won't look at her right now. That know which foundations can lobby and which ones cannot. But I put this here because it's obviously a very, very powerful tool for philanthropy to influence health policy. Even if the Kellogg Foundation can't do it, others can. So I wanted to complete the picture there. And actually, the very last slide I have, I had trouble putting together the slide. I'm going to have trouble sort of articulating it. So you're going to have to bear with me a little bit. But philanthropy and health policy. I mean, we got into this because of dental therapy, and we got into this because of the merits of dental therapy alone. You know, that really was why we did it. The dental therapy we felt by itself could improve access to care, and we were going to do our best to influence health policy. But as a collateral benefit out of that, we really learned a lot. There were some other program and policy opportunities that came out of the work with dental therapy. One of them was actually intentional. The other two were sort of, we just learned along the way. When I suggested that we, at the foundation, to move forward with this, I was actually hoping, because of dental therapy being such a high-profile topic, that would really raise the visibility of access to care issues with underserved populations, and that others would come to the table and really come up with alternative ideas, which we thought would be great. I think the more attention that we can get to this issue, the more it will benefit the underserved populations. So, and people that have been in this world longer than I have in terms of the oral health access world have said this is sort of a different time that they can remember, where people really are, in fact, talking about oral health issues. I'm not saying that dental therapy drove that, but I think it had a little something to do with some of the conversations. Even the people that oppose it are coming with alternative strategies, which is great. You know, the other two areas, you know, sort of just came up when we were doing the study, the evaluation for the Alaska Therapist Program. The researchers basically said, Al, you know, we're looking at we're studying the quality of care delivered by dental therapists very closely. We're looking at them under a microscope. We haven't done this in the dental profession as a rule. We just haven't done this. I said, that's interesting. I had never thought about that. And then I spoke to other folks in the profession and said, you know, you're right. There actually are not good consensus standards or measures out there to measure the quality of care provided in the dental profession. There just isn't. In fact, I know that right now because of this, I've gotten involved in it a little bit more and having conference calls with people to better understand it. And people are working hard to try to do it, but it's just not quite there yet. And coming from the medical side of things, and in my background in understanding the quality improvement agenda there and how it began a couple of decades ago and where it is now, you know, I sort of characterize it as sort of in the early adolescent phase of quality improvement on the medical side of things. And from what I've learned thus far from my dentist colleagues, is probably in the embryonic phase in the dental profession. It really is. And it's striking to me, and I think there's a lot of opportunities, because access is good, but access to not good quality is not good enough. You know, so I think some real opportunities here for policy and program work for private or public funders. And then the last thing I just want to touch upon, you know, people, really big thinkers said, you know, Al, dental therapy is good, and all these other suggestions to improve access is good, but, you know, we really need some dramatic changes here. We're really going to improve access for that 30% of the population. Some structural changes, systemic changes, major financing changes, sort of above my head. You know, I can't say I understand the whole dental world well enough, but I just wanted you to know that people are actually thinking out there of different ways of trying to improve access to care for underserved populations. I think it's great, and I would love to see Kellogg Foundation and other private and public funders come forth and address these and other issues to improve access to care for all Americans. So I'm just going to stop there, and I hope this quick overview of what one foundation has been doing with one particular project at least gives you a flavor of how philanthropy might be able to influence health policy. So thank you for the opportunity.
Thanks, Jeff. We have time for some questions, so please, let's have some questions.
Yes. I think we've gotten, it's an understatement to say we've gotten a lot of, I think it's an understatement that we've gotten a lot of pushback. We've actually gotten a lot of pushback. And I think most of the pushback comes from some of the organized groups of dentists. We've come to learn early on, and I've said this to many people, we were sort of operating in a foxhole when we first got involved in Alaska. Every time we put our head up, we feel that we were getting shot. And it took us a while to come out, and we probably had a little bit of a paranoid streak that wasn't very, very healthy, frankly. And then we come to learn that we realized that dentists are all different. They're all heterogeneous. And the more dentists that we've spoken to and that have the opportunity to share this information, the more we're learning. Many are just open-minded and want to learn more. And some have frankly come over and are the strongest champions we've ever met. But frankly, on the organized side of dentistry, they just haven't come across to that point of view yet. I don't know if is that accurate, sir?
Yeah.
As a dentist.
Yes. How does the dental
In Minnesota, I'm not as clear about it. Alaska is like a hub and spoke or wheel type of thing. So you have dentists. Well, let me just back up a bit. They supervise the dental therapists. Dental therapists have 2 years of training, classroom and clinical. And then they go through what's called a preceptorship period for at least 400 hours up to a year, working with the dentist side by side. And then the dental therapist determines what procedures within their scope of practice they can do off-site and which ones they cannot. And so that's sort of the planning, to make sure that when they're providing care off-site, that they're doing it safely. So that's sort of what I call the pre-supervision phase. Then there's the concurrent supervision phase, where if anything happens or any questions, they just pick up the phone or use some technology that exists in some of the villages to ask questions, et cetera. And then there's what I call the post-supervision phase, where their dental therapists are required to do a certain number of procedures in the presence of a dentist over a 2-year period to show that they're still proficient. So it's really all of that. Did that answer your questions?
Yeah, do they eventually practice independently after all of that?
They practice, well, they do not practice independently, just to be factual, they do not. But some of them practice on-site with the dentist, and some of them practice off-site using those remote capabilities to receive the supervision and to ask questions. Yes?
Can you talk about some of the quality measures that were used in the early study that convinced you to get involved?
You know, they were so long ago, I don't want to make up any things. I just remember the conclusions. I remember one striking comment out of one of the studies, in a Canadian study. They said, they basically looked at, and I have dentist syndrome, I'm going to really embarrass myself, but they basically looked at the fillings and how well they fit and things like that. And does that make sort of sense? But anyways, they did all that, and basically the conclusions were that technically, when they looked at the fillings that were performed by dental therapists and the same type of fillings performed by dentists, they were comparable. And the comment that really got me was they were as good, if not better than. And the reason I say that, in my earlier career, when I was involved with supervising nurse practitioners and getting doctors to supervise nurse practitioners, there were studies about the quality of care provided to nurse practitioners. And that language resonated with me back then in some New England Journal of Medicine studies that said nurse practitioners would provide these services, and their quality of care is as good as, if not better than, physicians. So that's why it really, why I remember that. But I apologize, I don't remember the exact methodology used for some of those studies. Yes?
I know you haven't been directly involved in the advocacy work, but you mentioned several states that have legislation on the table.
Yes.
Is that legislation always directed at changing the state practice laws to permit? Is that the kind of legislation?
Yes. Yes.
And has that already occurred in Minnesota? Because it's my understanding they were still trying to figure out what they were going to do with these people once they trained them.
Well, they actually passed the act in 2009. They've trained them. They're being deployed now, and they're being hired in different. So I know Health Partners. I just have.
They have to work under direct supervision.
There were two models. The one that's the people training out of the University of Minnesota can only practice under direct supervision, meaning they have to be in a room with a dentist. Okay, and then the other training model and I forget the name of the school, Normandy or Metro, I forget the name of the school, but basically it's a master's level training program. So I just want to let you know there's different models for training. I gave you the model that we're most familiar with in Alaska and a model that we're most familiar with internationally, but there are differences. So this other model I'm about to mention are people that hygienists that have 2 years of training after the baccalaureate, so it's a master's level, and they can, after the training and after some preceptorship, can practice under general supervision or a site away from the dentist. So there was, it's hard to keep up, I'll tell you. Yes, sir.
You mentioned that dental societies aren't totally on board yet with this concept. How about dental hygienists or organized societies?
It's interesting. The American Dental Hygiene Association actually have their own model Remember I said mid-level models is a generic term, and dental therapist is but one model. Another model is that proposed by the ADHA, and they came up with this model about 5 years ago after the Alaska model came into place. And their model is for bachelor's trained hygienists to have 2 more years of training, sort of what I just described, to be, I forget the term they use, advanced dental hygiene practitioners. But when you look at the scope of practice, other than prescribing drugs, it's pretty similar to what dental therapists do. So they support the concept of dental therapists. They prefer to be hygiene-based, that everybody should be hygienists before they become a dental therapist. Not everybody shares that opinion. Internationally, though, one should recognize the fact that some countries that started off with dental therapists, oh, by the way, I didn't know this, but in many other countries, they started with dental therapists before they even heard of hygiene. In this country, it started with hygiene, and now we're, almost a century later talking about dental therapists. But in several of the other countries now, they started with dental therapists. Hygiene came on years later. Now they're actually trying to merge the training into a 3-year program for joint hygiene and therapists. So, it's an evolution. But to answer your question, they're supportive, but they would prefer a hygiene-based model. Okay. Team support those. The actually reimbursed. Medicaid reimbursement. I think for the dentists that are supervision as well. It's there. 6 months ago, as the dental therapist. Right, but people are deeply into them. Oh no, I think.
Is there practice that? I know what you mean. Practice and allow restricted to.
Yes. Yes.
Okay.
Yeah. Live in the villages. But by and large, residents.
I think we're about, but I get to make one editorial.
The boss.
Within 6 hours of this location, there are 2 reservations. On those reservations, if you look at the caries rate among adults and children, it is 90%. The dentist to population ratios in those locations are much different. There are a half to more than a half fewer dentists per population. So we have extreme problems near here. Now, we also have problems with inner city providers and with Medicaid patients. There are only 10% of the dentists in Colorado see a significant number of Medicaid patients. So there really are problems with access in this state also. So I hope we can find some solutions. Thank you very much, Al.
My pleasure. Thank you. Oh, thank you.